Hello, it's June 6, 2022. Welcome to This Week in Medicine, and thank you for waiting the past couple of weeks until we were able to get back on board. This Week in Medicine is brought to you by the Foxhall Foundation. Indeed, Dr. Yamamoto did 3 talks in 36 hours in Boston 2 weeks ago. He continues to travel spreading the message of the Foxhall Foundation, primarily how you can prevent a stroke. We have a wellness center which was closed for a week due to COVID, no doubt. It's hit all of us, and COVID hit our wellness center, but I think it survived very well. Classes are back on, and we're happy to have everybody return. We're working on some new classes for 2022, including trying to get yoga back in the wellness center. This is our location in Chevy Chase. So in the inbox were a lot of messages about, I have a cold. I thought it was allergies. It felt like a cold. What do you think it was with all of these emails? Well, for the majority, it really was COVID. So these people tested, they thought they had a cold, but after a couple of days became suspicious. And indeed, a lot of people did test positive. There are still some people who probably did have colds, and they tested negative on antigen tests repeatedly and PCR tests. But the preponderance of emails from the past 3 weeks were people who sent me an email or called the office and said, I think I have a cold. And within 24 to 36 hours realized that it was actually COVID. There are a lot of people asking if they should take Paxlovid to Europe. It's not part of the FDA indication, but you cannot get it in Europe. We do tell people to boost before they travel with a booster shot, but what if you've gotten all your booster shots and you're still immunocompromised? Then probably it is a good idea to try and obtain Paxlovid. Again, it's not strictly covered under the FDA regulation, but it's not available elsewhere, and our government has paid for it for us. Omicron, BA2, and BA4 and 5 are on the scene. We still have a preponderance of the BA2 species, although 4 and 5 are circulating. People want to get a 4th shot before travel. I think it's a good idea. To mask or not to mask, honestly, probably everybody who has gotten COVID recently was not wearing a mask at a social event, at a graduation, end of academic year ceremony. So if you really don't want to get COVID, just wear a mask. It really works. If you want to celebrate without a mask, you probably are taking a chance that you could get COVID. But again, is it going to be just a cold for you? Well, if you're vaccinated, probably. A lot of people have said their antigen tests are negative, and so is their PCR. And a lot of people are still testing positive on home tests and not really doing tests at a facility or a clinic, because home tests are still available. Every couple of weeks, I think 3 times now, covid.gov, that's COVID.gov, has released free tests to send to your home. I have been sending in a request for tests to my house every couple of weeks so that I have a supply at home, especially a supply for travel, which we'll get to. So the case rates of COVID recently, I think it started March 26th because that's when I first noticed that weekend that cases were going up, and I started prescribing Paxlovid, or as they say on the radio, Paxlovid. I just like saying Paxlovid. For me, it's easier. So it started around March 26th, and so now we're pretty much in a 10-week surge. This is an extremely long surge. It's probably the longest one we have had. I still think just by office counts, I'm averaging about 20 patients a week, so it has not gone down. I'm hoping it'll go down soon, but pretty much every day I'll have 3 to 5 patients who tell me that they tested positive for COVID. There is definite Paxlovid rebound. It's not due to resistant organisms, so it's not because people took Paxlovid and the organisms mutated or escaped. We don't think so. It's probably not a Paxlovid independent part of the COVID life cycle, meaning that a lot of people have proposed that this is what COVID does anyway. It comes and hits you for 5 to 10 days, goes away and is not detectable, and then comes back robustly with more viremia, meaning virus circulating in the bloodstream. So we don't think that's what it is. It may be really Paxlovid dependent, meaning that it has something to do with the interaction of your immune system, the virus, and this medication. This data did exist from Pfizer when they submitted to the FDA, so we knew this could be possible. And I think at this point, you have a 10 to 20% chance of this turning into a 3-week illness. The way this would be a 3-week illness if you get Paxlovid rebound is that you start taking the medication for 5 days at the first day of your symptoms or your test positivity. So after 5 days you finish, you may actually test negative then, and you may remain negative until about day 10. Day 10, your symptoms come back. You can have a fever again. You can feel chills, fatigue, sore throat. On day 10, you can test positive with an antigen test on day 10, and you may test positive until day 15 or even as long as 20. So if you're testing positive on day 15 through 20 after you've taken Paxlovid, then you have extended your illness to 3 weeks. This is a consideration for people on timing, people who have events to go to, people who are trying to get on a plane, especially if your symptoms are mild, especially if you've had 4 boosters or 4 shots. If you've had 2 shots and 2 boosters, you're pretty well protected against severe illness. So again, Paxlovid was created in an era and a time when we didn't have as many vaccinations and we didn't have treatments. So it's really very successful in people who've never been vaccinated. But it turns out a recent study showed that it's as effective for decreasing severity in people who are vaccinated and people not vaccinated. So it is a very effective drug, but this Rebound is a real phenomenon. I'm not really ordering as many of these respiratory antigen tests that test for parainfluenza, mycoplasma, all these other viruses, because quite frankly, this has gone down in the past 2 weeks. So I think we're seeing less influenza A, we're seeing less rhinovirus. Some of these viruses got kicked out, and now we're just dealing with COVID as a common cold and really not seeing as many of these other viruses, which did seem to peak about 2 to 4 weeks ago. So our recent surge at Foxhall Medicine, I think I've given out about at least 150 doses of Paxlovid. Were they all taken? Maybe not. A lot of people got it and reconsidered on the 2nd or 3rd day, which is fine because you can take this in the first 5 days of illness for efficacy and benefit. I do think there's a rebound in 10 to 20% of patients. I had one adverse outcome because a patient had to stop their medication due to an interaction with Paxlovid, and stopping that medication created some pretty nasty symptoms, which once we figured out it was from a sudden loss of that medication in the person's bloodstream, when we restored that medication and finished up the Paxlovid, that patient did fine. But so far, it has not been a problem to stop a statin or to stop a blood thinner. One patient had reduced dose because they had kidney disease, and everyone really could get Paxlovid, but the private pharmacies are probably excluded. So our local pharmacies were not part of the federal government distribution plan. So if you typically use a private pharmacy, you're probably going to have to use a CVS or a Walgreens, because those are the pharmacies that receive Paxlovid from the federal government at no charge to the patients. So don't try to get this through your private pharmacy. I don't think you can. I think it's better to get it through CVS. Now, update your travel plans. The U.S. government pays for Paxlovid. You could take it on travel with you. Again, it's not strictly covered in the FDA regulation about this, but you can't get Paxlovid abroad. So I have been getting emails from patients abroad who have COVID. It's a problem. If you have COVID and you are staying in a hotel in a European city, there are going to be strict requirements for you to test and stay before you can travel again. So if you want to make your life easier, pack 10 to 20 antigen tests with you. You might even do that if you travel domestically, because if you have these antigen tests and you get COVID, you can start testing yourself as early as day 6. Now, most people don't turn negative at day 6, but if you really want to get out of that hotel and get out of that town and get home, this is your ticket to freedom. So pack those tests with you. There are companies that exist that will give you a doctor's note or certificate. This is very popular in Europe because you can't leave Europe without this doctor certificate. We have already sent many of these letters on our Foxhall Medicine letterhead via email. So if you can get on a computer in a hotel in Europe and print up my letter saying, I am your physician, you have COVID on a certain date and tested positive, but now you're testing negative by antigen test, or it's been 10 days, I will write you that certificate and we will email it to you and you can print it at the hotel. So also, this one came up frequently. Pack enough of your own pills, your own medication to account for an extra 14-day stay, because that's probably how long it will take you to turn negative. So take extra pills with you on your travels. Omicron cases are still high, and again, there are these variants that are still circulating. The BA4 and 5 may be not as severe an illness, but boy, are they contagious. The vaccine still works. I haven't had anybody, knock on wood, hospitalized recently at least not since probably 2020. It is more contagious and the affinity for human cells is stronger. Again, consider wearing a mask. It definitely still protects you. And of course, CDC continues to recommend masks and travel, and today even released another statement in light of monkeypox and how you can wear a mask to prevent yourself from getting monkeypox. In fact, there are so many things that you can get in close quarters on an airplane or in a crowded TSA check site. Maybe you really should think about wearing a mask. There's a lot to protect ourselves from. Indoor masking still recommended in the Northeast. Paxlovid Rebound we discussed, yeah, it really does exist. Usually sometime around day 10 to 14, and you could test for as long as 20 days, and it is definitely real. So report your Paxlovid Rebound on the Pfizer website. You can just log in. It's very easy to do, but they do need to know about this so they can investigate the cause. There are many interactions with Paxlovid, certain statins. I just generally tell all patients to stop your statin for 5 days. It's not going to be a problem for most people. And then for a lot of patients, I'm having them stop their Eliquis and Xarelto, but maybe take a baby aspirin. So that's a good thing to ask. If I'm going to stop my DOAC, my direct oral anticoagulant that protects against stroke and vascular disease events, maybe you could go on a baby aspirin for 5 days. That could work for some patients. There are also some ritonavir interactions, which is part of Paxlovid. Paxlovid's 3 pills in the morning, 3 pills at night. Ritonavir is one of those pills. If you're on a selective serotonin reuptake inhibitor, which is an antidepressant or anti-anxiety medication, it can increase the blood levels, but probably not substantially, not enough to change your dose. Except for trazodone, which a lot of people take for sleep, you probably do need to decrease your trazodone by half. And it could inactivate birth control pills, but there probably aren't too many people in their 20s or 30s who are taking birth control pills who are at risk for serious illness from COVID, so there probably aren't going to be many people taking Paxlovid at that age anyway. I'm not sure Test to Treat is rolling out super great. A lot of people are reporting that trying to get Paxlovid through Test to Treat has not been super efficient. So again, having a doctor advocate for you is helpful. Let's talk a little bit about long COVID. This study was published in MedRx, but this website in particular and this place to publish is not peer-reviewed. So the purpose of this site is to get data out there fast so that we can analyze some of these clinical trials before they are peer-reviewed. So it speeds up release of information. This study is from Stanford, so it looks like it's a very good study. It's a characterization of over 2,000 adults who had long COVID. And it talks about the autonomic nervous system side effects. Again, this has not been peer-reviewed, but a lot of people are looking at the autonomic nervous system and its variations in the body after COVID as an explanation for long COVID. And we've been thinking for the past 2 years that this is probably correct because we have seen a lot of long COVID patients. So what is long COVID? Dr. Fauci described this as post-acute sequelae, things that happen, of SARS-CoV. So they call it PASC. So that's the other term for it, post-acute sequela of SARS-CoV. Have we seen this before? I think we have, and I think we see it a lot in people who have certain viral illnesses. Mononucleosis, mono, can come from cytomegalovirus, human herpes virus 6, Epstein-Barr virus, and there are probably other viruses that cause the clinical syndrome of mononucleosis. It's characterized by having a sore throat, temperature that's pretty high, liver blood test elevations, and a very characteristic blood cell called the atypical lymphocyte. This can be seen on the CBC blood count. I love this test. If I see atypical lymphocytes in a teenage patient, they don't have strep, they have mono. So the CBC blood test is crucial if you're diagnosing mono. And you also might have gray coated tonsils because a lot of people still have their tonsils. We don't take them out anymore. Some patients, not all, certainly not me when I had mono for 7 days. I had a sore throat and a fever. I just thought it was a cold. It was mono. But I wasn't sick for months with fatigue, exhaustion, sore throat, low-grade temperature. But there are people who are. And this is where mono gets to be famous because of the profound fatigue and exhaustion for months. And probably a lot of this is due to an autonomic nervous system reaction in some patients where they cannot get their energy back. They've just lost their mojo. And we need to help these people, typically teenagers, with adequate rest, adequate hydration. It's probably very similar to long COVID. Again, a reaction to a viral infection that is pretty intense. What's the autonomic nervous system? Because it is kind of crucial in COVID and this post-viral reaction. It's the part of your body that controls your blood pressure and blood pressure variation, heart and breathing rates. So when we check your respiratory rate, that can be altered because of the autonomic nervous system, and your heart rate can go wildly high. I saw a patient with post-COVID symptoms a couple months after COVID. So I saw her 4 months after she had COVID, and she was still having symptoms. Her heart rate when she sat in my exam room was 180 sitting. When she stood up, it was 220. So this person had dramatic heart rate variability. Body temperature fluctuations, your digestion can be off, like stomach cramps and nausea. Your balance of water and electrolytes, like your sodium and calcium, also can be off in the autonomic nervous system disruption. Body fluids, sweat and saliva and tears, like when you feel clammy and hot, that can be an autonomic nervous system symptom. Many organs are controlled through the autonomic nervous system, which is probably why long COVID patients feel so bad and they feel like it's their whole body, because it is. We have seen patients with long COVID. They've been either established patients or they've been referred to us because friends have said, why don't you go see Foxhall Medicine? They've been seeing patients with some long COVID. The treatment's primarily directed at autonomic dysfunction. We'll talk about that in a minute. You also have to rule out other things that are happening possibly from COVID as well. People can definitely have pulmonary post-COVID issues, especially those who have been on ventilators or people who have complicated bacterial pneumonia. So you may really need to see a cardiologist and a lung specialist to make sure you don't have other issues that are not long COVID. Pre-existing POTS patients, that's postural orthostasis tachycardia syndrome, they may have an exacerbation of their symptoms, because the reason they have POTS to begin with may be because they already have that mono-like reaction to viral infection. So this study, again, that I mentioned a couple of slides ago is from Stanford. 67% of these long COVID patients had a COMPASS score, which means a survey that is taken to see if you have symptoms of autonomic dysfunction, like what we just mentioned, the sweating, the digestive issues, the difficulty standing without feeling fatigued, the profound fatigue that comes along with long COVID. So 67% is a lot, and this is exactly what we have been thinking for the past 2 years, evaluating these patients, that they probably do have a significant amount of autonomic dysfunction, and this study does agree with that. It's not linked to severe COVID, so you could have a severe case of COVID or a mild case of COVID and still get long COVID symptoms, and that seems to make sense. The most common symptoms: fatigue, brain fog, headache, shortness of breath with exertion, because remember, heart rate and breathing are part of the autonomic nervous system. Body aches, palpitations, remember, heart rate is part of the autonomic nervous system. Lightheadedness, because when you stand up, your heart rate goes up, but your blood pressure goes down. And that lowering of the blood pressure when you stand up is not supposed to happen. Normally, our blood pressure lowers for a couple of seconds to a minute, but rebounds back up. And people who have autonomic nervous system dysfunction, their blood pressure stays low and they're standing for a long time, and they start getting lightheaded because they can't get blood to their head. So a lot of these patients have these symptoms, and you have to wait 30 days after illness. We had a patient come in sometime this past week who still had COVID and complained they were having long COVID symptoms. You don't have long COVID symptoms until you're 30 days after COVID. So some testing we do in the office is very basic. We can do your blood pressure laying, sitting, and standing, and the heart rate for the same. If we see these alterations in blood pressure and heart rate regulation, we can diagnose you with autonomic nervous system dysfunction just in the office. There's much more technical testing that neurologists do, but let's face it, it's hard to get into doctors right now, and certainly neurologists. So for us to do this in the office is a lot easier. Tilt table testing classically used to be done, but we can pretty much make anybody dysautonomic by putting them on a table and tilting them. So this is not a very good test, and in fact, it's probably too sensitive. It's not as good as just checking blood pressure sitting, laying, standing. So the treatment of long COVID should be aimed at treating the dysautonomia. Compression pants are great, or exercise pants that are tight, because it helps blood return to the heart and to the brain. So as much as it's hot right now, it's hard to wear compression pants. They are really helpful. You have to do salt loading, but under doctor supervision. Don't take this on by yourself. You need to have a doctor to help you with long COVID. Salt tablets are actually very nauseating, which will just compound the symptoms of long COVID because we know that this already causes a lot of digestive issues. So you have to administer the salt carefully and pharmaceutically in a way that's tolerable for the patient. There is prescription medication like midodrine, but again, under doctor supervision and a doctor who knows what they're doing. Exercise recovery under physical therapy guidance can also help. There are specific physical therapy plans that are directed exactly at recovery from long COVID. But again, you need a physical therapist who is familiar with these plans for exercise recovery, which helps blood pressure and heart rate get restored to their normal variables. It's actually kind of similar to POTS recovery, which we have also been doing for many years. This is Alzheimer's and Brain Health Awareness Month, and just to bring up an issue of brain awareness and our issue with baby aspirin, we had 2 patients who had a stroke and they were not taking their prescribed aspirin. So be careful listening to the United States Preventive Health Services Task Force. They're internists, like myself, family medicine doctors, pediatricians, behavioral health, OBGYN, and nursing, but you will not see a neurologist or cardiologist in this group. So be careful listening to them. Be careful to listening to them talking about prostate cancer screening because they certainly got that wrong. And be careful listening to them about baby aspirin because they're not quite the group that should be advising on how to prevent a stroke. That really should come from neurologists and cardiologists. Alzheimer's disease, how do we do this workup? Since this is Alzheimer's Disease Awareness Month, you need to rule out the reversible causes of cognitive impairment with lab tests. So there are blood tests we can do in the office for this. You need to get a brain MRI to rule out things that are fixable, like normal pressure hydrocephalus, or a tumor, like an acoustic neuroma. You can get a 2 or 3 hour neurocognitive test. This is really very necessary. The problem is it's hard to find these clinical psychologists who will do this testing. Imagine that it's like ADD testing for an older adult. It's very similar. We're testing your mood, we're testing your cognitive ability, your calculating ability. It's a long test, but it provides a lot of insight into how the brain is working. Then after you have your blood tests, your brain MRI, and your neuropsych or neurocognitive test, you go and meet with a clinical neuropsychiatrist to put all of this data together and decide, do you have a condition that falls within the realm of Alzheimer's disease? I find in clinical practice that denial of the memory impairment versus insight into memory impairment is a good clinical feature. I have patients who will deny they have any medical problem at all with their memory versus people with vascular dementia who say, yeah, I forget things a lot. Usually someone who admits that they have memory problems is not as likely to have Alzheimer's. You also notice personality changes and, of course, memory impairment. So Tony's tip of the week, please take an extra 14 days of pills with you when you travel. We certainly can send you prescriptions by email to a foreign country, but then you have to find the pharmacy. You have to get a pharmacist who will give them to you. And some of these pills are hard to find in Europe. So take extra 14 days. Take 10 to 14 COVID antigen tests with you so you can get your ticket to freedom. And make sure you have a connection to a doctor so you can get your certificate to get out. So fast pitch, COVID might be a common cold. It certainly was what people were reporting the past 2 weeks. I have a cold. Paxlovid works, but it does have a chance of rebound. We are in a huge COVID surge, and by that I mean both length of time and numbers. This is a lot of people getting a cold. The masks can't prevent infection. A mask can prevent infection, but a booster may not. So just because you're boosted doesn't mean that you're not going to get this. If you go to a public event without a mask, you can still get infection. But again, is it going to be like a common cold? It might be. Pack wisely for overseas travel. You need your COVID tests and probably also need to make sure that you can get a certificate if you do get COVID abroad, and take your extra medication with you, your regular medicine. Thank you for watching. Again, attend to your pyramid of health. Discuss that with your primary care doctor. Again, this is our book, You Can Prevent a Stroke, which is still available. And please subscribe to our website. I think next week we will have another nutrition talk. Thanks.